Alrighty, so it's 12 p.m. Eastern by my watch, so we're going to get started. Welcome everyone to our webinar titled Fall Prevention Indicators for Use and Practice in Ontario, Childhood Falls Prevention, and this is facilitated by the Loop Junior Fall Prevention Community of Practice. My name's Michelle Dukeman. I'm the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. Parachute now sponsors the Fall Prevention Communities of Practice Loop Junior, along with the annual Fall Prevention Month campaign coming up next month in November. Before we begin, I just wanted to cover a few housekeeping items. During the webinar, if you have questions about the technology, please type it into the chat box. My colleague Marguerite Thomas will be monitoring comments there. But if you do have questions for our presenters about the webinar, please submit them through the Q&A box. They will be answered at the end of the webinar, and you'll only be able to view questions that you have asked, not questions posed by other participants. The webinar is being recorded and a YouTube link will be sent to all participants in about 1 week, along with the presentation slides. And you can view previous webinar recordings simply by heading over to Loop Junior, the archived webinars page, and clicking on archived webinars. But I would like now to introduce you to our presenters, Alexia Medeiros and Dr. Sarah Richmond. Alexia is an epidemiologist in injury prevention at Public Health Ontario, and Sarah Richmond is an applied public health scientist in injury prevention at Public Health Ontario. For a complete bio of our presenters, please view that on the Loop Junior event page. So without further ado, please take it away, Sarah, and I'm going to let you share your screen now.
Thanks so much, Michelle. I really appreciate it. I'm going to turn my video off just to be able to have as much of a seamless presentation as possible. I can't believe in 2021 my internet is not working as well to support a video at the same time I'm doing a webinar, but just to prevent any lag in conversation or discussion, I'm just going to have my video off and then it will turn it back on at the end of the presentation. So I'll just share my screen. Okay, just making sure that everyone can see that. Thumbs up from someone. Yep. Yes, thank you. So the way that we're going to do the webinar today is to share this presentation or co-present between myself and Alexia. I'm going to start off and kick off with some background in Child Falls, as well as to provide some background on this project. Alexia is going to then share her slides and discuss the methods for this project, as well as the results, and then support and facilitate some discussion and questions. We are actually going to stop for discussion throughout this presentation, specifically at the results section, where Alexia will be presenting the indicators as found through our environmental scan. So we'd really love for you to participate in discussion to better find out who has used indicators in child falls prevention in their practice and how you went about doing that. So we are going to invite you to raise your hand using the raise hand icon at the bottom of your Zoom, and Michelle will unmute you so you can be able to participate in discussion, and we're really looking forward to that. So we wanted to start the presentation today by understanding who is on the webinar with us. So Michelle is going to facilitate a poll for us to better find out who is on the webinar today and what sector that you represent. So thank you so much for participating in that poll. It looks like we have a lot of public health people here today, some government, not-for-profit, some that represent the academic sector, as well as regional health authorities, and those that work in ER or ED trauma and hospital. Thank you so much for participating in that poll. go. So as many of you on this webinar probably had the chance to review the cost of injury report published recently by Parachute in collaboration with the University of British Columbia. And in that report, looking at the mechanisms of falls by age group, falls represented the highest cost of injury in children ages 0 to 14 at $996 million annually. When we further look at falls by mechanisms in this age group, the 0 to 14s, breaking that down into 0 to 4, 5 to 9, and 10 to 14, we can see that other falls is the leading mechanism of injury for both 0 to 4s and 10 to 14s, with playgrounds being the leading cost for those ages 5 to 9. The other falls category is one that sort of plagues us in injury prevention to better understand the true mechanism of fall and what's contributing to these high direct and indirect costs. But the categorization includes those falls from buildings and trees, falls while being carried, diving, and those in that infamous category of unspecified. So while understanding the costs associated with child falls is certainly a necessary piece of information to develop a program of public health, particularly looking at these costs across these age groups as being quite high annual costs. It really presents a bit of a challenge to practitioners when these are the data that we have access to in order to better understand what are the specific mechanisms of injury when developing a program of public health. When we're looking at child falls in Ontario, these are data from the Public Health Ontario snapshots, the injury snapshots that we have at Public Health Ontario's website. And in 2019, there were over 4,000 ED visits per 100,000 population due to falls in children ages 0 to 19. There were over 100 hospitalizations per 100,000 in 2019 Ontario that were due to falls. And as we can see here, the rates certainly aren't increasing over time, but they are also not decreasing, which sort of gives us or presents an opportunity for us to really look at child falls, look at the categorizations of child falls and the way that we populate indicators for child falls to better understand where we can address the problem. This is a map of Ontario demonstrating the rates of child falls in 0 to 19 by public health unit. And I apologize about the pixelation on this image, but really this is to show that there is quite variability in the rates of ED visits by public health unit. This also is a bit of an old map with our existing 34 public health units in Ontario that are a bit of a legacy public health units that are changing with the changing structure of public health practice in the province. You can see here that the highest rate is just over 7,500 per 100,000 population in Grey Bruce Public Health, with Windsor Essex having the lowest rate at just over 2,000 ED visits for child falls. This variability across the province can create a situation where addressing the need for child fall prevention work could also vary across the province. So to address public health practice in Ontario, very early on in my role at Public Health Ontario that started in the fall of 2017, I had the opportunity to complete a situational assessment of injury prevention practice across the provincial public health system. Our goal was to identify capacity building priorities for injury prevention and really to better understand what injury prevention practitioners do across the province and how Public Health Ontario as a provincial organization can support the work specific to injury prevention. We wanted to identify priorities for both scientific and technical support, and really to gain a better understanding and relationship with public health unit staff to increase opportunities for collaboration and networking. The way that we went about this work was over a series of phases. The first was to collect some data that included reviewing existing provincial standards and guidelines, the existing surveillance data, as well as evidence briefs and other knowledge exchange products that were available to us. We conducted several key informant interviews with public health practitioners across the province, as well as attended 5 public health units for a site visit to get to know how people were doing injury prevention practice in Ontario. We asked very specific questions about the strengths of public health practice, challenges, as well as as I was mentioning, what support Public Health Ontario can play in supporting injury prevention in Ontario. We completed a thematic analysis that was informed by an interpretive descriptive approach to gather all of that data into themes. This is a bit of a busy slide. As well as indicators to support collaboration, the driver of this project specifically, as well as to do this work in older adult falls where the burden of injury is also very high. So the objective of this project was to develop a list of indicators for use in child fall prevention for a public health practice. This work was initiated by the Situational Assessment, also in response to requests from members of the Ontario Child Injury Prevention Network that was formerly facilitated by the Ontario Neurotrauma Foundation, and of course now Parachute. And we wanted to complete a project for child falls indicators that followed an older adult falls project that I had mentioned that was a little bit further on in the methods. So really the project goals were to really understand who is working in child fall prevention in Ontario and how people are using data and indicators to either report on the work that they do or inform a program of public health. We wanted to understand what indicators currently exist for child fall prevention, not only nationally or in Ontario, but nationally and internationally, and develop a list of indicators for child fall prevention to support systematic collection and reporting. So I'll just hand it over to Alexia.
Thank you. Great. Perfect. Thank you so much, Sarah, for that background and intro. So now I'm just going to shift over and discuss briefly our methods and then go into the results and then facilitate some of that discussion that Sarah had mentioned. So to do this project, obviously we did an environmental scan, and to do that, we first conducted a peer-reviewed literature search in several databases, as well as a gray literature search. And we did a title and abstract screen with 2 reviewers, and then we retrieved whatever sources we deemed relevant, which were sources that featured any potential child falls indicators, which you will see as we move on. We're not necessarily just true indicators, but anything that we thought could inform this project and child fall prevention more broadly. And we did include English language sources. And so we abstracted all that data, and I will now move into the results. And in doing so, we identified 5 broad categories of indicators or other relevant measures and considerations. So the 2 first categories, being population burden indicators and healthcare facility indicators, are what we've sort of described as these true indicators. These are ones that are largely collected in some sort of systematic manner by some sort of healthcare organization and reported on in some way. Some of those were in Ontario or Canada, but also we identified indicators that were collected and reported on globally. The other 3 categories, being the risk assessment tools, the severity, mechanism, and sort of context of falls, as well as the knowledge, attitudes, and behaviors around falls, are what we described as sort of other considerations. Now, these on their own, I wouldn't necessarily deem as indicators. However, they are things that we found to be important when we are moving forward and trying to develop a list of indicators for use in public health practice, and just included a lot of information that we thought was very rich and really contributed to kind of a fulsome picture of child falls globally, and all these sort of important measures and considerations in developing those indicators. And as I go forward, I'm going to describe these categories in greater detail. And then, as Sarah mentioned, after each category, I would like to take a pause and facilitate some discussion with the group to ask you if you use these indicators and sort of in what way. So I will make a note of that when it's time for that to happen. So the first category of indicators are these population burden indicators. Now, these are ones that we are all familiar with, some of which Sarah mentioned, and they largely describe sort of interactions with the healthcare system due to falls. So those include emergency department visits, hospitalizations, and mortality, as well as primary care visits for injuries due to falls and length of stay in hospital after a fall-related admission. Now, I will urge you to take a look at these for a second, take a pause, and I would like to ask the group if any of you have used these in your work and what way that you do that. So that can be things like use it to inform programming, or if you have access to the data or report on the data, anything like that. If you have interacted with these in any way in your work, we would love to hear about it. And I will also ask, if you do wish to participate, to just give a brief summary of your name and where you work so we can know who's contributing what. Thank you. So I will pause and invite you all to participate now. I also, because I have my screen open, cannot see who is putting up their hand or anything. So if you are putting up your hand, some other people on the call here will ask you to share.
Thanks, Alexia. Yep, the raise hand function is just at the bottom of your screen. So if you're willing to participate and share a little bit, please just click that there, and then I'll see that you've raised your hand, and I'll unmute you so you can speak.
Thanks, Michelle.
No problem. Randy, I've unmuted you, so you are able to share if you'd like.
Oh, perfect. Okay, thank you. Just to let you know that I use the hospital trauma registry. I work at Sunnybrook in the Torrey Trauma Program in the Center for Injury Prevention, and so regularly speaking with our registrars and understanding the data that we have in the hospital, and looking at that over time as well to inform our injury prevention strategies.
So Brandy, can I ask you, from the trauma registry, do you report on just LOS, or you report on all of these indicators that you see on your screen?
Oh, yes. So we'll have all of this.
Right.
So the trauma registry won't include the emergency department visits. That's in a different database.
Right.
So I would have to contact somebody else, but the registrars are one door away from me. So that's usually the easiest point of access. But yes, we regularly use whatever data is available to us at the hospital to help inform. It's just that the trauma registry is the easiest one for us to access.
And do you find that there's a specific way in which you use that data? Do you use it just for, maybe sort of populating an understanding of burden, or?
So we're trying to make the connection between the data that we have available to us and what that means for our prioritizations for injury prevention.
Right.
So it's a question that I don't think has been asked before in the hospital, and we've been working on this for a couple of years. So we recently created a report this past summer that looked at the last 5 years of our trauma data, and also connected it to the Ontario Marginalization Index. So we're trying to look at our patient population and understand better what their needs are, social, economic, where they're coming from in terms of the geographic spread, the types of injuries, and trying to stratify in a different way than the hospital would normally do. The hospital would normally just, we'll get a report each year that says we had so many males, so many females, we had, and then they'll create a pie chart of the injuries that we see, the mechanisms of injury. But that doesn't tell us enough about the patient population. So we wanted to dig a little bit further. So really looking at it through the lens of injury prevention and public health, and some of those pieces.
Right. We heard pretty overwhelmingly when doing that situational assessment that piece around sort of more about risk factors in falls particularly was a data piece that we heard from most practitioners in the province, and that actually initiated us to develop similar indicators, as you were saying, using OnMarg. So we've actually done it for falls for older adult falls and child falls as well. We haven't been able to put those indicators on our equity snapshots yet, but those are coming. There's a little thing called COVID that got in the way of us being able to do that right away, but that actually is something that we had heard overwhelmingly in the situational assessment as well. So that's good to hear.
Thank you so much. Again, I can't see if anyone else has their hand up, so please just let me know, and then I'll know when to move on to our next category.
No one else has raised their hand for this particular category. So we could give a last call and then potentially move on to the next one. And yeah, no more raising of hands.
Great,
so
thank you.
Go ahead, Alexia.
Great, and if anyone thinks of something sort of later on that you didn't get a chance to speak to just at this point, we will have discussion later, and also you're welcome to throw it in the chat box as well, just if something sort of comes up as I'm talking. So our next category is what we deemed healthcare facility indicators. Now, these are distinct from the last ones that describe sort of interactions with the healthcare system and describe the burden of falls. And these were very specifically ones that were collected and reported on specifically within healthcare facilities, primarily hospitals. So these were things like pediatric falls within the hospital, whether hospitals were taking various fall prevention measures. So that was sort of consulting with families or having posters up about fall prevention, specifically whether healthcare practitioners were being given fall prevention education sessions, as well as things like if newborns were being dropped or fell, mostly in that case dropped, I guess, within the hospital, as well as some other ones about different types of falls, different categorizations of falls. So I'll give you a second to have a look at them here. And again, I'm going to pause and ask the same question if any of you have ever encountered any of these in your work. A lot of these were from international sources. A lot of these were collected at like individual hospitals or individual hospital networks in the US and some in Australia, for example, not necessarily at any sort of national or systematic level, but they were very hospital specific. But again, if you have encountered any of these in your work, we'd love to hear about it.
I'll let you know when a hand gets raised, Alexia.
Thank you.
I know the feeling of that screen sharing and being totally blind to what else is going on. So
yeah, absolutely. I don't want to pause for too long, but yeah, thank you for letting me know and helping to facilitate.
I'm not sure, Brandy, if the ER trauma healthcare was just you that responded on our poll, but if there is any others that work within a healthcare facility that could share their experience in using even risk assessment tools that are associated with these outcomes, it would be really interesting to know if that's something that we do here in Canada.
And I'll go back to the first slide as well, just so you can have a look at those. Or even in this case, this paper was talking about tracking whether fall prevention education sessions were occurring. But even I would love to hear if if you work in a healthcare facility, if you have attended a fall prevention education session or if something like that even exists, that would be interesting as well.
So no hands raised on this one, but again, feel free to share in the chat if you are a little speaker shy and you'd rather just share via text, that's okay too. But yeah, so no hands raised yet, Alexia.
Thank you. Yeah, and these ones, I mean, I kind of anticipated that these ones, as I said, were mostly internationally. I don't think any of them came from any Canadian sources, so I guess that is to be expected. Okay, so I will now move on to what we described as other considerations. So this included 3 subcategories, which were fall risk assessment tools, sort of a severity, mechanism, and context of fall-related injury section, as well as one describing knowledge, attitudes, and behaviors towards fall risk and fall prevention. So I will first go into our falls risk assessment tools. This was really interesting because I honestly didn't anticipate finding any child-specific fall risk assessment tools because it was something I had mostly seen in the older adult space. So when we found quite a few, 4, that were specific to children, I found that a very interesting discovery. Now, they all in their own ways have several items that consider things like age and gender, as well as sort of their developmental status, whether they are, and whether they are potty trained, what their cognitive abilities are, whether they have any prescriptions or any other sort of diagnoses or health conditions. So they all do those in slightly different ways in order to come up with a fall risk score. So again, I'll let you have a look at these, and I will once again ask the same question if you have used any of these in your work. And these, again, when we were looking, did seem to come primarily from international sources. So I, wouldn't be surprised if no one has really used them frequently in their work here in Canada.
We thought it was a really important part of the indicator work to bring forward, as what we've seen in the older adult falls work is that the connection between the risk assessment tools used in the older adult space with the outcomes or outcome collection of outcomes that then inform indicators creates a bit of a gap, or there is an existing gap. So we thought it would be really interesting to have conversation about the use of risk assessment tools in Canada, whether or not they are used in Canada, and then whether or not there is any connection with outcomes specifically, or a sort of a collection of outcomes to inform an indicator, because it's, again, as Alexia was saying, not a familiar space for us in child fall prevention. And so one that we wanted to better understand, given the amount of risk assessment tools and outcomes associated in the older adult fall space.
Yeah, Helen, thank you for mentioning in the chat that it was a bit of a surprise for you as well to find out about these. I remember Sarah and I having a discussion when I had included these in my first draft, and she was like, "Oh, really? Are you sure these are for child falls?" And I was like, "Yeah, I was surprised to see them as well." And so if none of you have used these in your work, perhaps we can shift the maybe question to if you maybe would find these useful, or if this is something that you would like to use in your work. I mean, it's hard to know maybe if you haven't, but if you do have any thoughts more broadly, even if you haven't been able to use them yourself, we would love to hear that as well.
Brandy, I've allowed talking, I've permitted talking.
Thanks. Just one point and one question. The first is props to the authors on the titles of the tools, Humpty Dumpty and Little Schmitty. Those are my new favorite things now. My question is, are these tools intended to be used in like in a healthcare setting, or are these just general tools that can be used anywhere?
Yeah, great. First of all, great observation. This is something that Sarah and I have definitely laughed about quite a few times in the naming as well. And yeah, so what I found was these were primarily used in healthcare settings. So for example, a child would be admitted to hospital for whatever, they didn't specify necessarily. And then these, this sort of one of these tools would be used to assess their fall risk in that context.
It's interesting. I don't know if there's anybody else on the call who's from a pediatric healthcare center that would know if these are being used. Yeah, has anybody had any conversations with the folks at Sick Kids or GEO or Holland Bloorview, places like that?
Those are some great suggestions to maybe reach out to people who are working in those spaces and try to get some of their thoughts on these. Thank you. We have someone, Allison Sterling, mentioned in the chat that I'll just read out here for everyone to be able to hear. She says, as the knowledge broker for Loop, I have had a few requests about fall risk tools for children, especially in hospitals. So Humpty Dumpty was used by 3 requesters. What was missing was a post-fall assessment tools, especially neurological. Interesting that you have gotten those requests. Great. Okay, so clearly there is some interest in using these, which is good to know for sure. Great. Well, I'll do another last call maybe for thoughts about this, and then we can move on.
And yeah, no hands raised on the last call.
Great. Thank you, Michelle.
No problem.
There we go. Okay, so our next category was sort of about the context of falls and fall-related injury. So specifically constructs like the severity of an injury and the mechanism of falls, as well as some sort of more post-outcome concepts. So whether, what the admission outcome was after a fall-related hospitalization, and then also some about places where falls are occurring. So how many falls are occurring in a daycare setting, and then more broadly, just where falls are occurring among children and youth. And what we heard a lot sort of in our consultations with the child injury prevention group and even with the adult falls is, I think what people would find really useful for intervention planning and specifically targeting intervention is knowing more about this mechanism of falls and where they're occurring. Because I think, as someone had mentioned earlier, just sort of understanding broadly how many are occurring in a given time period doesn't really give you enough information to go on to sort of start to address those things. So this is where these sort of concepts came in. And again, as I said, maybe not all necessarily indicators are on their own, but definitely very important pieces to include when looking at some of those more broader indicators. And again, I will let you have a minute to kind of take a look at these, and any thoughts on sort of that context of falls or any of these in particular is welcome.
No hands raised, but I think Ellen put a question in the chat. If you're able to elaborate a little bit, Alexia.
Great, yeah, so I'm just looking at it now. I can absolutely also go back to that specific source and sort of give you more information about what they said. From what I remember, I think it was about, I guess, the child's outcome after they were related, I'm describing it as it's said here, but after they were admitted to hospital for an injury. So I think that can consider things, for example, maybe like any cognitive impacts if they had a head injury, for example. And I'm trying to think of any other context they gave, and I'm not remembering specifically what the source said about sort of the details of that. So maybe I could follow that up for you. And then I guess that I think it also potentially maybe described something about, the length of stay in hospital after that admission occurred. So I guess beyond just tracking whether someone was admitted for a fall-related hospitalization, sort of what the outcome for that child was and related to their injury and how long they had to stay in the hospital and recovery, sort of concepts like that. Yeah, thank you for the question. Great. Well, as we discussed, I mean, these aren't individual indicators, so I wouldn't necessarily expect anyone to have used them in their work, but I think it just echoes that desire for just more context around these indicators and these injuries to really be able to inform intervention planning, because without some of those details, it's very hard to know where to direct your planning. So I'll take one last call, I guess, again for this one, and then we can move on to our last category. No hands, I take it, Michelle?
No hands, no.
Great, thank you. Great, and this last category we describe as knowledge, attitudes, and behaviors towards fall risk and fall prevention. Now, this is sort of a mixed bag. They primarily came from very specific studies assessing the knowledge, attitudes, and behaviors of either teachers, parents, kids themselves about injury risk more broadly in a lot of these cases, and then some were very fall specific. So a couple of these, for example, researchers would go into the homes of new parents and do an assessment of the injury risk within their homes, and they would look at things like burns and drowning risk as well as falls. So it was sort of one small piece within a more broader, study. And generally, they were assessing sort of how much, for example, teachers or parents know about the fall risk of their children or their students, and sort of what actions they were taking to prevent that injury risk, as well as some specifically, a questionnaire specifically administered to children about their individual injury beliefs and risk assessment. And then they looked at sort of a before and after program about sort of they educated these children on their injury risk and then did the questionnaire again. So there's kind of a mixed bag, as I said, but more broadly, I think speaks to this idea of how much people know about their personal or their children's injury risk and sort of what they're doing to prevent falls specifically and injuries more broadly. And then there was also this one, which was interesting, a fall prevention score that was assigned to countries at the country level by the European Child Safety Alliance. So that one was interesting as well. Yeah, so I'll let you take a look at these again. And again, I don't necessarily expect anyone to have used these specifically in their work, as they were international and from very specific studies. But if you have any thoughts more broadly about these concepts, we would love to hear about them. It was also interesting to see, specifically when looking at these, how much falls was just sort of slotted in among injuries more broadly, and how in a lot of these studies they looked at a bunch of different injury topics without much focus on falls individually. And I think that sort of indicated to me how this space definitely needs some more attention. Especially because it's difficult to just consider all different injury topics, together, as they all sort of require specific. Oh, sorry, I have a specific interventions. I'm just opening the chat here now. Okay, yes, they will be, the slides for the question here, they will be available after the webinar. A recording and the slides as well will be emailed out.
Is there anyone that works in the Healthy Babies, Healthy Children program in public health on the webinar today?
Vicki, I've allowed you to speak, so you can unmute yourself and share.
Yes. So I guess what exactly do you want to know about the Healthy Babies, Healthy Children program?
So just wondering if there's any type of programming that is specific to injury prevention, I guess child fall prevention in the home visiting program?
Yeah, because of COVID, we don't have time for a whole bunch of that kind of stuff right now. But for those of us that are still doing that, between the public health nurses and the parent resource workers, we do offer a budget annually to buy safety items for families. So that includes baby gates and that kind of stuff, which then we can give to the families, and then we follow up, do the education, and then follow up and make sure that they've actually installed the gate and that kind of stuff. So there's nothing specifically that we have that we talk about for fall prevention, other than like the safety item kind of aspect, or if we're in the home and the child's starting to become mobile, then we'll do the education on like child safety and fall prevention will be part of that.
Right. Thank you, Vicki. That's really great to know.
No problem.
Great. So I'll kind of give another last call about this category, and then we can sort of wrap up this section and then open up the discussion to questions and discussion more broadly. Great, Michelle, no hands, I take it?
No hands.
Great, thank you. Great. So what we want to know then, sort of coming off of this and seeing maybe how few of these are used in work that's going on right now in Ontario and Canada, we would like to know what data you think would be useful to inform your work and what you think should be systematically measured. So you can use sort of the information that we provided here with some of those indicators and other measures, or any other experience you have that you could bring to that. And we would just like to sort of set a foundation for our focus group that is coming up in the coming weeks, which I will plug shortly, just to sort of understand really what is important to the people working in this space. So I'll let you have a think about that for a second. And then whenever you're ready, we would love to hear your thoughts. You know, specifically if you were at work at one point and said, oh, I would love to have this piece of data, this would really help to, you know, sell my program or inform sort of the action that I want to take. We would love to hear about it.
Vicki, I've allowed you to speak.
So yeah, just I think what is important for us is at public health units is specifically so that we can make a case for any kind of type of programming, post-COVID, we'll say, that any specific information for our own counties, right, our own areas, because if management doesn't see it as an issue to our local community and a need, then they won't necessarily provide us extra funding or time, resources, that kind of stuff to put a whole bunch of extra work into it other than what we do regularly. So that's what I find always good, if it can be like more targeted. The problem is the numbers can tend to get so watered down by that time that you can't even pull out the data for like Elgin and Oxford, right? Sometimes because there's not enough.
Great, yeah, no, that's a great consideration, absolutely.
And I wonder how much that's going to change when the existing structure of public health units is going to change. As you know, looking at the Public Health Ontario snapshots, they exist by public health unit, and as you're saying, sort of the specificity at more of a local level might be important to inform planning, and then we maybe move to a structure that increases the geography of the areas in which we serve. That might present an increased challenge in better understanding the way in which we sort of target our interventions. I know early on at PHO, understanding that the snapshots function from guidance from a THEO, and that guidance for most of the injury mechanisms or injury types on our snapshots put children in this large category of 0 to 19, which for a lot of uses is not helpful to inform programming. And so the first step in sort of breaking down those age categories to that's more specific and useful to the mechanism that we're talking about here, obviously being falls, and following, you know, guidance and other reports in this area, like the parachute report on the 0 to 4, 5 to 9, and 10 to 14 could itself be very helpful as a starting point. But, you know, I find that the not understanding more about the context of the injury is where you know, systematically in Canada, that we don't have enough information, we don't have enough data to support our public health programming, where we're not necessarily sure how these injuries are happening.
And Brandy, feel free to go ahead.
Sure. And Sarah, I think you led perfectly into my comment in terms of the need to understand better the protective factors. And just looking at the list of the knowledge and attitudes and beliefs charts, a lot of them come off as very negative, which I understand working in this space. But when we only talk about risks and deficits, we're not really learning the whole equation to understand what those protective factors might be. And I think that also ties into Elaine's comment in the chat box around the social determinants of health and how that ties in too. So I think in terms of what data would be useful is all the stuff that we don't know, and trying to find a way to reframe the fall prevention equation as a more positive space to work in around those protective pieces. So what is it that we can do to help people not fall? And I know that we don't have that, but I think it's important to just put it out there that's maybe some of the work that we should be focusing on is that better understanding of the other part of the equation. I'll leave it there. I could ramble forever.
Great. That's a very interesting framing, because I think in a lot of work we talk about risk factors more so than protective factors. So switching that framing, I think was really interesting, and it's definitely making me think about some of these in a way that I haven't before. So thank you for that.
Chantel, you can go ahead. I've allowed talking.
Thank you, Michelle. I just want to echo or reiterate the point that was just brought up about the positive spin, if you will, on the fall prevention work, because we've been having some of these conversations nationally and also more provincially or Atlantically here. I'm on the East Coast. So we've just been chatting about, well, there still exists a misunderstanding or sort of a lack of maybe the right language to use when we're framing fall prevention and all of the work that needs to go into it. There's also, on the other hand, such a great amount of positive work being done or, you know, progress made that we've all kind of had a part in over the years that we could and should be focusing on as well. So I just wanted to reiterate the fact that I totally agree with the positive and the protective factor focus as well as we move forward, and seeing some more of that data to support that particular stream would be really helpful.
Great, thank you. It's excellent to also hear when multiple people sort of have the same thoughts and agree on the same things, so we know we're sort of coming up with themes in the right direction. And so that's great to hear. Thank you for both of you who shared. Great. Are there any other thoughts about these discussion questions at this point?
Just wondering, Alexia, if we can open some conversation around whether the participants in other provinces have ever initiated work in this way to better understand at a provincial level who's working in the child fall space and what they are reporting on. I know there's been a lot of work, Chantel, out in the East, and I know Kathy's been involved in a lot of work out in Alberta. And I'm just wondering if there is other work that has sort of echoed this this project in the sense of trying to better understand who works in this space and how they are doing the work that they do. Our work has obviously been challenged by COVID, but previous to COVID, starting this project, it was a bit of a challenge to understand even just the sectors that whether or not we've captured the sectors that work in this space accurately. And we're hoping to not only better understand that for Ontario, but whether or not this project maybe lends to more of a national conversation around reporting for child fall prevention. It could be great timing for those from Parachute in the release of the cost of injury report in the summer to look at the age breakdown and the associated costs, and that falls was the leading cost associated in children. So it might be sort of opportunistic to talk about this at a national level over a provincial level.
Go ahead, Ellen.
Hi, it's Hélène Gagné at Parachute. Just to reply to you, Sarah, so one thing that will be coming out is an infographic that will summarize the information from the cost of injury report that Parachute released. So that's one piece of information, more of a knowledge product that we hope is going to have the ability to be shared more widely. And for your point regarding the national discussion, in doing an environmental scan of interventions 2 years ago, Brian Heinemann did that. And interestingly enough, not all provinces knew necessarily which sectors were involved in fall prevention per se for children. So it was a little bit more sporadic. And I think your question is a good one, Sarah, in terms of, are we reaching out all the sectors that we should reach out in terms of getting them involved in the discussion and also knowing what they're doing?
Yeah, it's a great point, Hélène. I look, thinking of that intervention scan, it was quite similar to obviously our environmental scan, in that there's quite a limited number of interventions to support work in the child falls space. Here, seeing that there are few true indicators for child fall prevention, and just sort of putting that in context and sort of juxtaposition with the work in the older adult fall space. We have a list of over 40 indicators in the older adult fall space to work with, and thinking of the use of those indicators across sectors and prioritizing them for sort of a systematic approach to reporting on older adult falls. And the gap there that we identified pretty early on was that, there's several indicators to establish burden, but less so in more of a programmatic space to reflect necessarily accurately the work of public health. And I've always wondered, in talking to colleagues at Public Health Ontario, whether or not child fall prevention just sort of works and maybe exists in this gap between those in injury prevention practice and those in healthy growth and development practice. I don't know if anyone has any thoughts or comments there.
Yep, go ahead, Hélène.
Just to build up on the point that Chantal made, there is a group that is having these discussions nationally, and we are looking at maybe it is time to reach out to other practitioners than the usual suspects and go to sectors like the educational sector and the leisure sector, and looking at the different age groups that you mentioned, Sarah, and the burden there, but also having those conversations as to what is it that they see themselves contributing to the issue of fall prevention in children, and whether it's something that they're looking at. So So I think that to answer that question, we're going to have to do things a little bit differently and reach out differently.
Agreed. Thanks for that, Helen. I'll just hand it back over to Alexia to sort of inform on our next steps, as well as to invite everyone to participate in our upcoming focus group.
Great, thank you, Sarah. So our next steps, as we just mentioned, are a focus group. Now, we are hoping to run this focus group to sort of discuss this list of indicators that I presented to you today, and develop a list of indicators that we think are important to use in this space. So some of those can come from the environmental scan, ones that already exist, but also open up the conversation to recommend new indicators that we think would be useful for people in their work. So we also hope to understand sort of who is working in this space, what indicators they use in-house. So hopefully, you know, in that conversation, we can address that question in a little more concerted way. And then we're going to get our participants to recommend new indicators that they don't currently use, but they believe would be useful for their work. And in doing so, we hope to reflect on 3 specific criteria that has been established in previous work in this area. And those are the usefulness of indicators, the feasibility of collection and reporting, as well as the ability of an indicator to prompt action in this space. So we're going to sort of keep those 3 criteria in mind while we facilitate this focus group discussion. So I'm just going to highlight it here, and we will follow up in an email with all of this information, but we really do need participation. I think because of COVID primarily, we've definitely not gotten as much participation throughout this project as we had hoped, and we're sort of making this final push to really be able to complete this phase of the work. And everyone today has had such great commentary and feedback that we would invite you to participate, and really love you to participate in our focus group on this day. And also to say, if you know anyone else maybe wasn't here today, or you think would like to participate, to also share this invitation with them as well. And so just to wrap up, talking about the implications for practice of this work, we hope that to come up with a list of indicators that really reflect the desires and needs of people working in the fall prevention space. We want to capture some of that context, as we mentioned, mechanism and severity of falls, perhaps shift of focus to some more protective factors, as we discussed today, and really just understand what individuals working in this space need, and reflect that in our list of indicators to hopefully make a push for them to be collected and reported on in Canada going forward. In doing so, we also want to support the systematic collection and reporting of some of these indicators. So, for example, we hope to maybe centralize some of this reporting at Public Health Ontario, maybe rather than individual public health units having to do all the work themselves, and maybe are duplicating efforts a little bit. If we could work towards having Public Health Ontario snapshots report on some of these indicators, and take some of the burden of doing that off of other groups, we think that would be really beneficial. And then also, of course, once things are collected in a more systematic way, we're able to better track trends over time across geographic regions, and really get into some of that nitty-gritty detail that would be useful, as some of you mentioned, for planning your interventions and also getting support for those programs. And so I'm just going to wrap up by another plug for our focus group. Again, this information will be emailed to you, but that is happening on Tuesday, October 26th at 10:30 a.m. If you are currently interested, if you know that you will be, we'd love to have your email in the chat box if you want, and we can email you directly, but we'll also follow up with those who are here today and remind you of this. And yeah, we don't have a ton of time, but I will just use this last minute to ask if anyone has any questions before we wrap up.
Great, thank you, Alexia and Sarah. I'm just gonna share my screen for a couple of final housekeeping item before we separate today. But I just want to thank you both for such a great presentation and sharing your extensive knowledge of this environmental scan, its implications for practice, and also just creating this space to have some really great discussions today. So that was a really great session. It looks like most of our participants' questions were answered through our discussion. So I'll move on to a couple of closing housekeeping items. In case anyone does have any last minute questions, feel free to add them. But when the webinar has ended, you will be redirected to Zoom and invited to participate in a short evaluation survey. You just click the blue continue button on your browser and you'll be redirected to the survey. We really appreciate if you could provide your feedback so we can continue to offer these high quality webinars like the one we just experienced. Now, Marguerite, I'll turn it over to you to say a few words about Loop Junior.
Thank you, Michelle. And I would just like to extend the invitation. If you are not already a Loop member, please join www.fallsloop.com, and then you can see where you join the Loop Junior. Thank you so much for this presentation. The Loop Junior website will be archiving this. You will also get the webinar in your email, but all of our webinars are archived, and that's part of the advantages of belonging to Loop. There are many other advantages, so please join if you are not already a member. Thank you.
Great, thank you so much, Marguerite. It doesn't look like we had any final questions spill into the Q&A box. So I'll close. We're a little bit of a minute over, but thank you all so much. And thank you, Sarah and Alexia, for such a great presentation. And I hope everyone has a wonderful rest of their day.
Thank you.
Thank you.
Thanks, everyone. Bye.